Welcome all of you. My name is Robert Greif. I'm the current Director of Training and Education, and we have today a webinar on teaching children basic life support. It's a rapid fire session, which means we have invited several speakers, and they will give a short presentation on their projects. So we have an overview of what's going on all over Europe. I welcome all on Zoom and also on the YouTube channel. When we announced this webinar, the response and registrations were so many that we had to close the Zoom registration and open the YouTube channel. So thanks for your large interest. I'm doing this together with Pat Conaghan and Federico here at Semeraro. We are the moderators. Maybe Pat is a nurse from Manchester teaching there. Pat, some words from your side.
Welcome everybody. We've got a fantastic panel here and I'm sure this will be a really interesting and enjoyable session for everybody.
And the next moderator is Federico, a consultant anesthesiologist from Bologna, Italy. Federico.
Hi to everybody. It's a real pleasure to spend some time with you this evening. Welcome in the ERC webinar.
Only a few words how this works. Please use Slido. You have the link in the chat for your question to the audience. The chat will be not attended by us. The chat is for you to say hello to all other people and communicate in between you. Please send your question to Slido and we will bring them into the discussion. And without any other stuff, I hand over to Patricia to start with the first presentation.
Thank you, Tino. So Jan Breckwald is our first speaker and Jan's going to introduce himself, tell you all a little bit more about himself. So Jan, over to you.
Yeah, thank you, Pat, very much. Thank you for this introduction. And I'm an anesthesiologist and emergency physician presently working in Zurich, in Switzerland. And I did some Kids Save Lives projects in Berlin and now in Switzerland. I'm going to tell you a very small slice of what we are doing at the moment. And I'm going to just sharing my screen. There we go. And I'm sure there is so many different Kids Save Lives projects all over Europe that I didn't want to just bring up a new project and show how the project is going, but just show a small slice of what we looked in now, say half a year ago. My conflict of interest is down there. I'm a member of the ILCOR Task Force, Education, Implementation and Teams, and I have some other occupations with medical journals, and I have this project, Kids Save Lives in Zurich. So in the next 5 minutes, I'm just going to give you some thoughts why we did this, this project or this part of the project, what we did, what we found, and whether there were any consequences. So we were interested on the perspective of the kids on the courses. So we designed a best practice course, which we thought would be appropriate for kids. And this course, of course, was designed by healthcare professionals. So we took a 90-minute time frame and had an intro, practice part, a scenario, and a wrap up in the end. And you can see that was 15 minutes and a lot of practice, even 1 hour of practice in small groups with 3 facilitators. And at the end, we had the wrap up. So what we did with this course, we taught this course to a whole school and asked in the end of the course via a method called stimulated recall over 30 minutes time, 2 children and 2 teachers who were taught on that day or on that course. And we took 4 video sequences from the course, which we showed the 2 children and 2 teachers, let them think aloud on what they saw and what they thought could be improved and what they liked. We audio taped this, transcribed it, and made a qualitative content analysis on that, which is a typical qualitative method. And what came out was, that's just one of our results, that from the 255 comments, 1/5 related to the video. And what the children and also the school teachers said was that the video was highly valued, but this was a video which was taken in the hospital with healthcare professionals, and it included ventilations also. So there was a lot of suggestions, especially by the children, how to change or improve the video. So one was, let the children resuscitate, to show that children are able to do that. They wanted the video to be serious at the one side, but also to be cool. And they recommended to go into the public, could be outside or maybe to a gym hall or a restaurant or whatever. There were a lot of suggestions. What they also wanted, they wanted to include the emergency medical services. Our consequences from that was that for the World Restart a Heart Day in the last year, we produced a video of about 4.5 minutes. It took us a whole day, and we took the video in a public garage. We had all kinds of professionals in the set, of course, kids, resuscitating, the city police, who are involved in as a first responder in Zurich, the Zurich EMS, and a professional camera team. And you can watch this video on the YouTube channel, or you can just take the QR code right here and find the YouTube by the QR code. So the take-home message is that kids have great ideas and that kids can save lives. That's it.
Thank you very much, Jan. And I've had a quick look at the video, which I have to say is excellent. And it's really nice to see the kids taking such a lead in that video. So can you tell us a little bit more about the background to the project?
Well, the background is that we want to establish Kids Save Lives program within the community. And I'm convinced, I'm deeply convinced that the only way to really anchor Kids Save Lives projects is to go into the responsibility of the public. So it is, we have to take the politics in there, and we have to involve the authorities, the health authorities, but in this case, the school authorities. And this is what we're doing. We are working on this since probably 2 years, and now it's a bit postponed because of COVID, and it's so difficult and so on. But I think the other problem is that it sums up to, say, 2 million francs over 5 years, and they have to be invested, and someone has to be convinced that they say, well, this is an important project. This has to be sustainable. We won't see results very quickly. So we try to calculate the lives maybe saved, the quality adjusted life years. And we gave this these figures, we gave it to the school authorities, but still they have difficulties to adapt that program. So we're waiting on that. We're waiting for someone to spend the 2 million francs over 5 years. But that's what is going on at the moment.
Thank you, Jan. As I said, I had a quick look at the video and my German is very weak, but I thought it was really excellent quality. Do you think that other people could use this YouTube video in their own teaching?
Well, we are planning to have English subtitles, so you can use it at least within the English courses. So it would be a didactic double-decker. But I think it's pretty self-explanatory. So it's not really necessary to have the German words spoken. You can see how the children act. You can see how they activate the EMS and how they fetch the AED and what they really do. So I think everybody could use that even without subtitles.
Yeah, I agree. It is a really high quality video. So thank you very much for that. And you've actually answered my question in terms of where do you go next? Obviously, it's getting through the politics and getting the sponsorship and funding. So thank you, Jan. I'm going to hand over now to Federico, who will introduce our next speaker.
Thank you, Pat. It's really a pleasure to introduce you, Christina and Christian. They will talk about a very nice, amazing project about teaching BLS. Christian, Christina, the stage is yours. Please introduce yourself.
Thank you very much, Federico, for the introduction. Let me share the screen. Okay, can you see it?
Yep.
Okay, good. Firstly, I would like to thank the ERC for the invitation to this webinar, especially the moderators, Patricia, Federico, and Robert Grave. And thanks as well to Lars for all his support during the preparation of the webinar. My name is Cristian Abelairas Gomez. I am assistant professor of physical education at the University of Santiago de Compostela. And I'm only the visible part of a bigger, great and multidisciplinary team from Spain. And with me today is presenting these slides, Cristina Varela Casal, who is associate professor in the University of Vigo, and who is the artist, the designer of the Endless Book and the Rescue, these new approaches to teach BLS to school children. So in this presentation, we want to start with describing the Endless Book. The Endless Book, we chose this name due to the way in which the Endless Book works, because it's a graphic and narrative resource, a storybook, which tells a story about a sudden cardiac arrest and how school children should intervene facing this scene. So it works as a loop in 4 different steps, and always we repeat the same order. So the story is telling always in the same order. We can see how the Endless Book works in this slide. The first thing would be the keeping calm. The second one, the checking response and checking breathing. The third one, alerting EMS. And finally, the communication with the dispatcher in terms of who is calling, what is happened, and what is happening. We can see that after the 4th step, we start again with the first one. The order of the sequence is always in the same order. The second didactic material is the rescue, and it's a cube made up of 8 smaller cubes, and it becomes, in addition, in a rectangular block. the main difference between the rescue and the endless book is, in this case, the sequence is not necessarily presented in the same order. So the school children can explore the different ways of the different phases of the cube, and each phase of the cube is one of the steps of the BLS sequence. We can see in this slide the different phases of the rescue. The first one would be the sudden cardiac arrest. We follow with the scaring of the witness, and finally the rest of the BLS sequence as in the endless book: keeping calm, checking response and breathing, alerting EMS, and finally the communication with the dispatcher. We can also transform the cube in 2 rectangular blocks, summarizing all of the BLS sequence. Now we have only the cube and the endless book in Spanish, but we are roll out to this project to different languages. In this slide, we can see the scientific assessment of these new approaches. We were able to train, to educate in BLS more than 200 school children, split in 4 different groups. School children taught with the rescue, with the endless book, with a cuddly toy, and with the mannequin. After the training, they were assessed 1 week later and 1 month. And in this slide, we show the results, the main results of the assessment after 1 month from the training. Regarding keeping calm, alerting EMS, communication with EMS, and the performance, the correct performance of the complete sequence, the endless book and the rescue groups were superiors than the other groups, than the mannequin and then the cuddly toy groups. Only in the step regarding the checking response and breathing, the mannequin group was superior than the endless book group. But in general, these new approaches show superior than the traditional approaches compared to the mannequin and cuddly toy. So finally, some key messages for taking home. We know that the school children are not adults and they can learn basic life support. We have much evidence that demonstrate that school children can understand the contents of basic life support, but we should adapt the teaching and learning process to the psychoevolutionary development of the school children. In this regard, our group trying to develop the endless book and rescue, including iconography especially designed to teach this target population, the school children. Finally, our results show that both adapted didactic materials, the rescue and the endless book, were able to increase the competencies and retention over 1 month compared to a mannequin or a cuddly toy. So that's all. Thank you very much for your attention, and I will be very happy to respond any question from the audience or the moderators.
Thank you, Christian. Thank you, Christina. It's a very amazing project. There is some question from Slido. First of all, is possible to have some information if you put some link about your project on, because there is somebody from Barcelona are very curious to have some content with you, and a very, I can say, art topic for you. It's possible to ask to the kids to build on their own this cube as a laboratory, as a, I don't know, as a homework. Is this possible? Is too much for them?
Very nice question, Federico. Now we contact with a company to perform this material, and we now we only prepared the endless book and the rescue for this project, but now we would like to roll out the project for the people. But it's not easy to create this. Is one of the limitations for the students in schools. we have to prepare them.
Okay, thank you, Christian. If you can put some contact on the chat, because there are a lot of maybe are interested to have some information from you about this nice project. Tino, I'll give you the scene.
Thank you. For all of you who are listening, you can download information from all these projects and from all the speakers. There are PDFs and the speakers placed their contact. So if you have a specific contact for whoever is speaking, you can write them and they are willing to give you the information, either the video, the slides, or whatever you need. So Lars will put again the PDF of this information on the chat, so you can download this also from the chat. And with this, I would like to switch to our next speaker, which is David Weidenauer from Vienna, Austria. And he will present us a very interesting project at the schools in Vienna. He's one of the group which is called Pulse. They started very small and could manage over the last years to a gigantic teaching project in Vienna. David is from the University of Vienna, also an ALS instructor. David, the floor is yours.
Hello, thank you. So hello. The project name is I Can Save Lives, and we've started 2013 with the project. The training takes about 2 hours per year, and the target groups are the children at the age of 8 to 9 and 11 to 12 years. And so more than 33,000 school children can be reached in the project every year in Vienna, and of which more than 90% get trained. What makes this project unique is that we use a uniform trainings equipment for every class and a uniform curriculum, which is edited by me. And the question is how to book a training in Vienna for the school class. Every September, the Education Directorate of Vienna is sending an email to every school, and the school teachers are able now to book a course for their school classes at our website for booking. And the ambulance services and the medical university and Pulse are getting the information from the website and about the date of the courses which are preferred by the schools. And now they are able to confirm the appointment and confirm it, the organization confirmed the booking of the website, and the schools are getting a confirmation email by the website. And the ambulance services are sending the trainers, and the medical university are sending the trainers, the students, the medical students to the schools, and they are doing the training at the schools.
Have you got a key?
Hello? Yeah. The trainers are paramedics from local ambulance services, from Johanniter Samariterbund, Red Cross, Maltesers, and the Vienna Ambulance Services, and medical students who receive special education training at first aid and are getting motivation and are motivated to train children. They're now getting every year a special training by teachers, school teachers, and to get information what is special to train school children.
David, may I ask you why you are focusing on trainers and not train the school teachers?
Yes, we did a research at school, and we asked the school teachers if they think they are able to train children right now.
Mhm.
About a half said, yeah, we are able to teach right now. About 25% said, yes, we can do it, but only after a course. And about 25% said they are not able to teach children, even if they're getting a training. So we're thinking it would be a good idea. It's not the cheapest way, but to send external paramedics, motivated medical students to the schools who are teaching the children. And the teachers could be the second trainer in school. So we have, if their teachers are motivated, they will get extra information from us. And so we can teach the school children with two trainers, external trainer and the school teacher who is hopefully motivated to support the trainer.
Mhm.
And the city of Vienna is funding the project. And the Helpers of Vienna, which is a civil defense association in Vienna and a sub-organization of the city, is responsible for the organization of the project. And the ambulance services and the medical university is getting the money for each course from the Helpers of Vienna, which are responsible for the whole money of the city of Vienna, which is funded for the project.
Good. How much does it cost?
By year, approximately 100,000 euros, 110,000 euros. And so we're reaching about 30,000 children. So I think it's acceptable. And the project leaders are the city of Vienna, who is funding the project, the Helpers of Vienna, who are responsible for the organization and coordination between the partners, and the medical university and Pulse. They are responsible for the curriculum and the research. They are represented by me. So I'm responsible for that. Our project partners are every ambulance service in Vienna. Every ambulance service is taking part of the project and are sending teachers, motivated teachers, to teach the children, and the Education Directorate of Vienna. The training takes about 2 hours. In the first hour, we are teaching this chain of survival, especially for the children, which is optimized for children, as you all know. And in the second hour, we're training the chest compressions, and the break between the 2 hours is taking about 10 minutes. And after the break, we are asking the children what they were doing during this time, and we tell them how long it takes until professional help will arrive at the emergency point. And so they can understand 10 minutes is a long time, and it is very important to be a person who is doing first aid, who is doing early chest compressions and AD access. And we will demonstrate the AD. If we have a lot of time, some children can do it as well. If we have less time, we just show it and show them the sign of the EAD and tell them how easy it is to use it.
David, can you come to an end?
Pardon?
Can you come to an end?
Okay. Yes. The project or the 2 hours is just the beginning. Every child gets a booklet of abstract, and they have a homework. They have to do the test with their children, with their parents or family members, and to bring the test on the next day to the school, and they will get a card, plastic card, like a credit card with the name on it, and now they're officially helpers in Vienna.
Okay, thanks. David, there are quite a lot of comments in Slido telling us that teachers are able to teach, school teachers are able to teach CPR to the kids. And you mentioned that in Vienna, there was the decision for professional healthcare providers. So what's your view on this? So would you change this, or what's your view?
I think the best way would be teachers are teaching resuscitation, but not every teacher is able or willing to teach resuscitation. And with this project, we can be sure that every teacher who is booking the course, the class is will be teaching resuscitation. And every teacher who is willing to support the project can support the resuscitation training during the 2 hours, or can talk about normal breathing or unconsciousness and other things before and after the training as well. So they can support the training. Yes. Okay.
Thanks, David. Very nice project.
Thank you.
Again, for all of you, please download the information the panelists and the speakers gave, and you can contact them directly for the material, if this is available in your language or translation or whatever information you need. And with this, I hand over now to Patricia again.
Hi, thank you, Tino. So it's my pleasure to introduce Gary Rucker, who's going to talk about a modular teacher training approach. So Gary, over to you.
Good evening, all from Rostock, north of Germany. I'm an anesthetist and helicopter doctor, emergency helicopter doctor, and I just want to switch over my screen. Give me a second. Okay. Okay, I hope you can see. Well, modular teacher training course of the German Resuscitation Council. First of all, I'm the chief of the Rosanna Medical Simulation Center of the University of Rostock, and there are no conflicts of interest. At the concept, just give me a second. The concept is just teachers are able to resuscitate a cardiac arrest victim, of course. They do excursions and things like this. They make small holidays with their children, so they have to do management for the cardiac arrest. Teachers are professional teachers, of course. They can give resuscitation lessons in schools, perhaps in sports or biology. The themes of this is very common to make just lessons a little bit more exciting. We took pupils from up the 7th grade, this is 12 years onwards, and 2 lessons annually. And this is a concept just we tried to realize. We do this on a teacher's course, 4 hours. First level, 60 minutes, check, call, push. And second level, 60 minutes briefing, mouth-to-mouth ventilation and IAD. And you see on the slide over there, this is one of our just big courses for the teachers. There are 200 teachers. I'm living in a small state. We have federal state in Germany. In the area I'm working in, there are 1.6 million residents, and we tried to roll this over 400 teachers now so far. So what is to mention about this? Involvement of the school health service, of course. That's a major topic, involving internal and external support options, first aid organizations like the German Red Cross and Malteser and whatever. We think the best way is just to give them the mannequins at home. You see the boxes on there, they had got some hand grips. You can put them at home, just to teach some of their neighbors or their parents or their grandmas or their sisters and whatever. And just we try to do exchange for the teachers every 2 years, maybe 3 years, depends on Corona, of course. Nowadays not working this year, but next year we hope we can follow this. Some problems. We got a federal school system, 60 ministries for a school in Germany. We have to convince the decision makers. Finance is a big problem for this. You know, we have to roll out over the federal states in Germany. You have to select the school project coordinators and the teachers, of course. You have to provide the teachers' course. You have to order the mannequins. Our aim is just to give every school one set of the mannequins. This is fast quality. It's about 30 of these mannequins. And this takes, of course, a lot of time. You have to organize it. You have to manage to bring it in. We have now in Mecklenburg-Vorpommern, this is the state I'm living in, we've got 12,000 of these mannequins on the run in the moment. And then just we try to work this. The concept, school teachers, trained pupils, is, of course, in our federal small state, well running. We got now 18 till 90% of all the pupils onwards 12 years. But the recommendation, the 2014, now only 2 of the 16 federal states have installed this statewide. So you have to cope with very high bureaucratic hurdles, financial responsibilities. You know what this for German means. German is very bureaucratic and very correct and things like this. This took much more time than expected. So the process is still going on, and we hope just to roll it out maybe till 2030. I think it takes a little bit of time, but you have to calculate it's much money that you have to spend in the project. And so you have to give the project a little time just to manage it for all the countries now via the GRC. The curriculum we did for the teachers is on this reference. We translated it from German for you in English, so you can download it. We give it in the link, of course, and the small description of this slideshow, and you just can download it in your language, and you can use it, of course, and you can copy it, whatever, do whatever you want it, take the best of it you like to. So thank you for listening for me, and now, of course, your questions.
Thank you, Gary. So one of the first questions is why school children at the age of 12 when there's quite a bit of evidence now that we can teach them at younger ages?
Well, this is a process. I think it's now 15 years I'm doing research on this. I did 1,000 children of our mannequins to research, and I asked all over Germany, over 10,000 pupils, what they think about it. And we talked over 400 teachers, what they thought. And the result is 12 is the best year to cope with the problem. And so we said, okay, this is much more research, you know, 11,000 pupils and teachers are enough just to make a decision when you can start it. So we choose 12 years for this.
That's brilliant. And given your experience, I'm going to pick up a question that's appeared on Slido a few times now. Have you, in all that experience, have you any evidence that a child has done something incorrectly? So there are a couple of places where people are concerned that if you teach a child to do BLS, they'll go and practice it on their siblings or they'll use it incorrectly. Has anything like that occurred to your knowledge?
Well, that's very easy answered, because we know 5 cases where the children from 13 and 14 years saved the lives of their grandpas and mas. So if you teach and the life saving has worked, there's no other way to explain this that it's working, actually.
But that's fantastic that you've got evidence it's working. But yourself or any other panelist, has anybody ever come across an incident in which a child has done something that's harmed somebody? Because that seems to be a fear that's being expressed in Slido.
Well, but this is all the adults as well. This was a reason. Actually, this is a great big point. This was a reason why we started pupils. We gave up training adults because they have always fear, and we put it in the part where the pupils don't have things like sexual things and secrets and things, whatever these are making fears. And so we start before they are getting into fear setting, you know. And so we said, how much could we go down to the years? What is a kind? When could we start earliest, just to go away from the you call it pubertät, but how do you call it pubertät? How when they got adults, you know?
Puberty.
Puberty, yeah, that's when we try to get it as far as it goes to the point, from this point to the point they are able to, and this is 12 years actually.
That's great. Thank you very much, Gary. And I'm going to pass back to Federico now, who's going to introduce our next speaker. Thank you.
Yeah,
Thank you,
you're welcome. Bye.
Thank you, Gernot. It's a real pleasure to introduce you, Clint, Jean-Louis. He talk about AED training. Please, Clint, the stage is yours. Thank you.
Okay, thank you very much. I'll just share the screen. Okay. Can you see the screen?
Can you make it a little bit bigger?
Can you see the screen?
Perfect.
Perfect.
Yes. In the first place, I'd like to thank the European Resuscitation Council for organizing this event and for inviting us to participate. Thank you, Tino. Thank you, Federico, Patricia, and Lars and Saloa for organizing the event. Also, very big thank you for all my fellow colleagues, instructors, and collaborators with the ABC Safe Lives program. We're celebrating 10 years in this 2021. In order to get into the AED training box, let's find a context. And an important concept we've learned is the learner's path, which actually means that when we started in 2011, and we had to find a way to getting into the schools. Spain was in a crisis at that moment. There was not much funding, so and we could not count on healthcare professionals to volunteer every year to go to schools. So we looked at teachers, and we found out that if teachers acquire competent skills in basic life support and feel confident that they're going to they can save someone's life, or at least assist someone in need, then after that, they could be willing to train their children. So what we did is we didn't teach teachers, forgive me for the what to do. We didn't tell them what to do. We actually learned that we should actually listen to them, tell them what children should learn, and then listen to them. That's the key part. So while we were focusing on physical education teachers, the education department told us to open it to all other teachers. So what happened is that other teachers came in, and we found out that cross-curricular activity actually strengthens the program in a school. We didn't look for teaching in a classroom, and they told us, no, let's go to the school community. So we widened up our view thanks to listening to them. We focused on physical education, and it was curricular in 5th and 6th years of primary school and 2nd and 4th year of secondary school in physical education. But what happens is that on paper is one thing, and in practice is another thing. So what we did is that we learned that if we have constant engagement with teachers, they will keep on doing it. And by listening to them, we also found out they from kindergarten and from the 1st year of primary school, they would start also teaching children what to call 112, to learn their address where they live, to find a person, an adult, a reference adult to call in case of any serious health problem to a family member at home. So this we've taught over nearly 2,000 teachers. And we actually focus on our physical education teachers because they are actually going to be teaching in schools. Now, this year, we hope that 100% of our schools will have at least 5 mannequins. Bigger schools will have between 10 and 20 mannequins. And then teachers, the physical education teachers teach, train up to about 7,000 students a year. And we'd have to add another a few thousand of other students from the early primary years and the rest of the whole of school life. Last year was a bit difficult because no training was done, but it was an opportunity to develop this AED training box, which you'll see. And the constant engagement I spoke of and the learning, an attitude of learning from teachers led us to find out that they actually asked for an AED trainer. That was not one of our objectives in the beginning. But in secondary school, they kept asking for us for one. And then we actually supplied 7 good quality trainers, but they didn't last for very long, and they are quite expensive. So we got our brains working, and we decided to create a product which is an app which is easily downloadable on the telephone, and a box which there's a short video. You may have seen it before, but oops, sorry. Oh. And the whole product is actually well designed so that every piece of the product is useful to the teacher. You see, even the envelope will come with the electrodes should be placed. It has also a little puzzle for students to do. Basically, practically any human being can construct this box within less than 10 minutes, and it's quite a fun activity if you do it in family or do it in a group of students or teachers. Oops, sorry. Okay, go to the next part. Now, the app is the central part of our product, where you have an instructor mode and a student mode. So the actual AED simulator was made within a month. And what happened is that we had to work with teachers to find out how they wanted to actually do the training. So we present 4 scenarios for training, each with an objective, with learning tips, with errors to avoid, with videos they can visualize, and they can also send to the students to watch. And then the fourth scenario is with the AED training, with AED simulator, which you see on the right side. They can also, on the left side, you can see that's the video which the students could watch, and you could also send them a simple test of 5 questions, which cover the basic life support skills that we'd like them to learn. As you see, this goes out to Federico. We recently did a refresher course with the Star Wars cast. As you see on the right side, we have the instructor has a remote control where he can control each of the groups, or each person who's with his own telephone and box doing a case. 3 weeks ago, we started a trial with 28 physical education teachers who actually implement the program in schools. We did it via streaming because the education department challenged us to do it this way. And then each teacher had a box, had one of these boxes. They have their own phone, and they had a mannequin at home. And the good advantage of this product is that you can access it from a computer, and you can even program the cases from home. So that's what I did at home. The 4 instructors, we programmed the cases for each of the teachers, and we were doing it to each of them in their own house. So the learning path I think it's important to have an open mind into listening to the teachers, because they'll give you the key to how to get to the schools and how to get to the children. As I said before, train them to become competent and confident lifesavers, and then help them to train, and then support them in the best way you can. Our teachers have a lot of the didactic material online, which is free for them, and we actually let them do their jobs. So they give us so much feedback, and they give us a lot of ideas that we help them to improve their training. Now, the AED training box, I'm sure, will be some things that actually comes from then, and I'm sure that it'll. We were fascinated by the way it's been working now. The next stage of our trial is for them to use it in the school. So we don't have results of that as yet. I hope we'll have it soon to be published and to share with you. And I think we're all here today because we have a common purpose, and we are very open to any collaboration from many around the world, around you. And let me say that perhaps we might not leave the world a better place, I don't know, for our children, but I'm sure with what we're doing here, I think we leave better children in the world. So thank you very much.
Thank you, Clint.
Well, you're most welcome to download the beta version, which is you can download and try it out. And if you'd like to contact us, please do so. Thank you.
Thank you, Clint. Very amazing presentation about AED box. Two very fast and furious questions for you. First, do you have any feedback from teachers, some preliminary feedback from teachers on the use of the AED training box in the schools? And they have some concern about any legal problem because children is not able to use AED. Do you receive some feedback from this about this? Thank you.
Okay, yes, thank you. The trial we're doing now with teachers who never ever seen the AED box before. We train them to use it and to use the app, and they will be doing it now. So that's what we hope to have. But over the last 3 years, we've been working with teachers who actually used it, and well, they helped us to develop the scenarios which you find on the app. With regards to the legal issues, in 2019 in Navarra, an AED can be used by anyone. You need to be certified only if you're a police, if you're a lifeguard. Certain people have to, or in a commercial center, you need someone to be certified and to keep doing a mandatory refresher course every 2 years. But any citizen can use an AED, and but obviously any citizen has to be trained. So that's what we're doing now. So we've addressed and focused our AED trainer on secondary school students. So we want them to finish school knowing how to do BLS and knowing how to use an AED. And they'll be above 16, 18. And any child who knows an AED, even if he's 12 or 13, can easily bring it. And I'm sure it probably, I mean, we give children mobile phones without any manual. So I don't think an AED will be.
Okay. Thank you very much, Clint. Tino, the stage is yours now, maybe.
Okay. I have to announce again from the technician that after this webinars, all the information, the PDFs with the description of the project, the brief summary, and specifically the contact details will be placed on social media. So you will have the chance to download and contact directly the speakers for the specific questions which are coming in on Slido and the chat. And with this, our next speaker is quite well known, Federico Semeraro from Bologna, and you might know it, but he's a really freak on virtual reality, augmented reality, and he will tell us how this can improve teaching for children.
Thank you very much indeed, Tino. Yes, I'm a freak, I'm a geek. I share my screen and I'll talk about how to teach children with virtual reality. I'm Federico Semeraro. I'm a consultant in anesthesia and intensive care from Maggiore Hospital, and my conflict of interest, I'm a geek, basically. Children BLS task force and chair-elect and BLS co-chair of ERC. So first of all, virtual reality. This is one of the definitions of virtual reality. It's in a galaxy far, far away. This strange guy called Yaron Lanier in 1987 coined the terms virtual reality. I started working on VR many years ago in 2009. First article and first prototype of VR for CPR training presented and tested during IRC Congress in collaboration with the Scuole Superiori Sant'Anna. Was an amazing experience with engineers that tried to develop something in virtual reality. Back to the Future, we use a serious game applied to CPR training for kids with motion detection technology, with Kinect. And we demonstrate that it's possible to learn quality CPR with serious game. And we measure the baseline of quality CPR of these students. We engage them with a serious game. They increase with feedback during competition phase, and they keep and they have some retention some months later. And this was our conclusion. So how cool is that virtual reality? We collect some point of view from some key person some years ago. Yes, we can use it. Why not? In 2017, Resuscitation UK developed Lifesaver VR. It's not a real virtual reality. It's an immersive and interactive film for CPR training. It's like a live action movie that you play like a virtual reality game. It's not a virtual reality, but use the VR devices and sense of immersion. You can interact during the video through your smartphone inside the cardboard and with the use of accelerometer inside the smartphone and measure chest compression rate. And recently, have a look, because two trials about Lifesaver VR, very interesting about the use of Lifesaver VR as a tool to teach and learn CPR. In 2018, in a galaxy far, far away, seems a long time ago, we started for 1 year a research and development about VR CPR under the umbrella of ERC, a virtual reality experience in out of hospital, in hospital with adult and pediatric patients to learn and teach CPR with the user ID. We use it extensively during Cardiac Arrest Awareness, World Startup Day, with kids, general population. We organize competition as a serious game with the use of quality CPR, the same approach of the previous project that we call Relieve. So after that, we compare the data from VR CPR versus standard mannequin, and we demonstrate only a small difference between motion detection technology and traditional mannequin. So for this reason, we organized before COVID area a BLS and quality CPR pilot study for a care professional and general population. We also, for example, on the left, Oculus Go for knowledge and learn procedure and algorithm, and we use the Vive on the right, Vive platform with head-mounted devices, sensor on the wrist to measure and give feedback in real time, exactly similar to a quality CPR device. And take-home message: virtual reality may represent a powerful tool for cardiopulmonary resuscitation training for school children. Serious game VR apps should be included in future CPR educational approaches and combined with obviously face-to-face education. I am a believer, so virtual reality, from my point of view, should be considered as a blended learning approach for school children, and teach and learn as soon as possible VR to the children. Think different, think outside the box, and do not conform. Thank you very much. Open to your question.
Very nice presentation, Federico. I have a question. Do you think there is a difference for virtual learning for different population groups?
Could be, because, you know, the next generation, they are able to use an iPhone. They spent a lot of time with PC. Maybe they are more comfortable with the new technology. But overall, I think VR, it's the only real side effect is motion sickness. So if you are not very keen to flight in a virtual reality, maybe you are a little bit feel a little bit discomfort during the virtual reality experience. I'm totally sure that kids are absolutely able to fly in virtual reality and use the VR as a normal iPhone.
Mm-hmm. And another question, because we have knowledge, skills, and attitudes, do you think virtual reality can focus on different things, or where's the purpose of virtual reality?
Yeah, I believe we can use appropriately for different reasons. So you can use, for example, Oculus Go is a very passive experience. It's like you are immersed in a video in 3D, so you can learn algorithm. So it's about knowledge. in terms of attitude, you know, the sense of disbelief in virtual reality, it's amazing. So there are several research that if you receive, I don't know, a puncture in virtual reality, your system react as in real life. So in terms of attitude, the immersion in virtual reality could be very useful. For example, there are several research about agoraphobia, or to treat some psychiatric disorder in virtual reality. For skills, obviously, you have to have wrist motion detection technology. So we use it extensively for quality CPR training, because we can measure with wrist and head-mounted devices all the motion during CPR. And so definitely we can use for knowledge, skill, and attitude. But I am a believer, you know, we have to demonstrate this. Okay, thanks. And with this, to our next speaker, and Patricia will be moderating.
Hi, welcome again. So it's a pleasure now to hand over to Nino Fujako, who is going to talk to us about mobile apps to teach children basic life support. So Nino, over to you.
Okay, thank you very much. Just tell me if the PowerPoint is showing.
Yeah, perfect.
Thank you. Just a minute. Start. Okay, first I want to thank you for inviting me to this webinar and giving me opportunity to present our work. My name is Nino and I am a teaching assistant at Faculty of Health Science in Maribor. I'm also a PhD student in medical faculty of Maribor, and I'm very interested of mobile learning, and I will represent this today. Authors do not have any conflict of interest. Today, mobile apps represent a powerful didactic tool for teaching children. In 2020, a back-to-life hack in form of basic BLS elements was added to one of China's most famous game, Blood River. When gamers lost their life, they could perform CPR on their characters to bring them back to life. During 2 weeks, over 3 million gamers performed BLS training and learned how to perform BLS. And these gamers were young people. The aim of this study was to systematically evaluate the quality, usability, evidence-based content, and gamification feature of the commercially available mobile apps for teaching school children BLS. At first, we searched commercially available apps. We used Google Play Store and App Store and represented the result in Prisma flow diagram. The agreement between the authors was high. When we selected the apps, we evaluate them using different tools. For app quality, we use mobile application rating scale, user version, which provides data for performance, functionality, aesthetics, and quality of information. For app usability, we use system usability scale. The agreement between healthcare professionals which evaluated the apps was high for UMARS and low for systematic usability. Gamification was evaluated using the 26 gamification features represented here, and the agreement between the authors was also high. BLS content was evaluated using 17 BLS action, which were generated based on European, American, and Australian BLS guidelines, and were visually represented in 5-figure mnemonic. And also the agreement of the authors was high. So we started with more than 1,000 apps, and with inclusion and exclusion criteria, we evaluated 6 apps in the end. But the main criteria was that we are looking in interaction games. All of the apps were developed in collaboration with healthcare organization and were part of the council or association. Overall app usability was poor to okay, and Breathtaking Picnic has the most usability content, which is showing here. Overall, the quality of the app was graded as average. Here is the data, which is showing that a first aid action hero app and Breathtaking Picnic app has the most quality content. On average, the gamification was well represented in this figure, especially gamification feature in personal slash fictional and performance gamification group, and last in economic, ecological, and social gamification group. Half of the apps taught hands-only CPR, while the other half also included ventilation. All the apps indicate when to start the compression. This is showing here, and only one app taught BLS using an automated external defibrillation. In conclusion, overall, the quality of the app was average based on NUMARS. The usability was poor to okay based on SAS. The quality of the BLS content was poor to average in terms of alignment of international BLS guidelines, and gamification feature was well represented across the gamification taxonomy. Key message, I represented 3. Improving the quality and the usability of BLS content and combining them with gamification feature can offer educators novel mobile learning tools for teaching school children BLS skills. Using an adapted 5-finger BLS teaching mnemonic, which is represented here, a mobile learning with gamification features, there is tremendous potential for teaching school children BLS to improve survival rates of cardiac arrest. Based on this review, for teaching school children BLS, we recommended using a Breathtaking Picnic app in the age group of 6 to 8 years, First Aid Action Hero app in the age group of 8 to 10 years, and Everyday Lifesaver app in the age group of 8 to 18 years. So thank you for your attention. This study is available in this QR icon. If you have any question, don't hesitate to ask me. You can email me or find me on Twitter. But I also want to say a happy Nurse Day to all of the nurses, because today is International Day of them. Thank you for your time, and see you next time.
Thank you, Nino. I was fascinated by the Chinese game. Has anybody attempted to do something similar in, I'm afraid I'm not really good. Is it Warcraft or something like that? Is a great big international gaming scene, World of Warcraft?
Yeah, it's one of the most popular game, but nobody included basic life support content into this game or something like that. But what was included in the second, maybe the most famous game in China, which was mentioned in the beginning, it's called Blood River, but it's similar.
Well, there's something for somebody to get into then. What did you think was the kind of best app? I mean, you've recommended 3 for different age groups. Was there such a difference that they fit with the different age groups?
Yeah, if we use based on NUMARS, for example, the quality, no, not quality, the difference of how to play this interactive game are graduated. So we recommend that Breathtaking Picnic is for younger generation, and more sophisticated in the bracket is not so it's not so appropriate for younger children.
So do you think a child at home could pick up any of these apps and learn BLS with no previous experience?
I'm afraid not yet, because of the mistakes, or simply to simplify we recommended that first they have initiative training, and the mobile apps, this one which I represented, can be used for retention of the knowledge and skills at home environment.
Thank you very much, Nino. Another thought-provoking presentation there. I'm going to hand over to Federico now to introduce our last speaker.
Thank you, Pat. Thank you, Nino. I am the father of Breathtaking Picnic. So thank you very much to mention Breathtaking Picnic. I am the father. So
I know that. So
thank you very much. This is my conflict of interest. I'm totally afraid I'm a geek. Sorry. So it's time to Jason from Yorkshire, UK. Please, Jason, send us some message about your experience, and the stage is yours. Thank you so much.
Good evening, everybody, and thank you for having me on this webinar this evening. What I want to talk to you about tonight is how we build a sustainable model for delivering CPR training, and it's somewhat daunting having following all the previous presentations to hear of some of the fantastic work that's going on. So we are building a model around this strapline of making Yorkshire the place to live and survive, which I can tell you as a man from Lancashire is actually quite galling, being the neighbouring county. So what you see here, on the infographic on the left is a summary of our Restart a Heart activity. So we started Restart a Heart mass training in Yorkshire in 2014. And the model that we sort of developed within the ambulance service was then subsequently adopted by other UK ambulance services in 2016, as well as the first international partnership, which we forged with Ambulance Victoria in Australia. Now, of course, as you'll all be well aware, Restart Heart has become this global phenomenon with activity in every continent. But I think some of the figures in that graphic, for me, are quite astounding, and to realise that in one day in 2019 we trained over 46,000 students in 163 different sites using 860 people who volunteered their time freely to come in and deliver that training is quite astonishing. And since 2014, cumulatively we've trained over 150,000 students, having reached 82% of secondary schools in our region. And what we've been able to do as a result of that is look at a piece of research, or we've done a piece of research rather, that has recently been published, and this looked at a correlation between Restart a Heart activity in a postcode area and bystander CPR rates. And what this inferred was a non-significant association between bystander CPR rates and Restart a Heart activity. But I think crucially, as well as recognising the face-to-face training element, which is obviously vital, we've had to adapt as a result of COVID, as everybody has last year. And last year we introduced online training as well, and this was assisted with the introduction of our pillow partner. So a simple pillowcase with CPR instructions on it that is freely available to people for less than, well, it's a couple of £, if they want one. And they can receive training anywhere they choose to, as long as they've got web access to and can access our online training platform. But I think it's worth mentioning social media. Social media is a great platform for getting our messages out. The message around, anyone can save a life. It takes two hands to save a life. Kids can save life. Social media is a huge platform, and particularly as we've talked about technology in this webinar already, children, young people are well versed in a lot of the technology that's out there, and we need to make as much use as possible of those platforms. So what next? And I think we've reached a point, having done this for a number of years now, where we need to consider how do we continue this? How do we sustain it? And how do we build upon it? And what we want to do is we want to be able to deliver training more often and in more locations and to reach more people. And in order to do that, we need to develop this model that doesn't rely entirely on our staff or volunteers to deliver that training, because we simply don't have the capacity within the organisation. So what we've done in consultation with a number of schools and teachers is we've built a model that allows us to shift from this teacher-led training that you see on the left there to peer-led teaching. And this supports student development. It also allows the school to achieve some of the statutory requirements that they have in terms of being assessed for their educational delivery. So in order to do this, what we are doing is we're attempting to build a network of ambassadors, Restart Our Heart ambassadors. And this is helped by the fact that in 2020, CPR and first aid was incorporated into the school curriculum in England. So it is now mandated that children will receive this training in their school. And this, of course, means that it's an easier sell in a way into schools, that this is something that they have to deliver, and we can provide them with an alternative solution as to how they can do it. So the way it will work is the ambassadors will be trained by us and supported by us to deliver the training. We'll provide them with all the materials, and the benefit is that the students can then perform the training and deliver the training rather at a time that suits the school, rather than being dictated to by us as a service as to when we can come in and do that. So we provide a flexible framework that allows them to deliver when it suits them. The consultation with teachers was really enlightening. Everyone without exception were all really extremely positive about the role, and some of the key things that kept being mentioned, you can see on the post-it notes there, that it develops leadership and skills in young people and empowers them. It meets the school's need to provide enrichment activities with their curriculum. And crucially for a lot, it develops future skills and also builds towards their career aspirations as well. And there's a lot more words that I could have put up there. I could have probably put 30 post-it notes up on the screen there to illustrate the kind of benefits that come from this program. But it's clear to say that it was definitely well received. But very much connected to the ambassador scheme, we've also offered schools an accreditation scheme. And this is a 3-tiered accreditation scheme for schools and colleges to work towards, to evidence how much they're doing to train the students and also their communities in CPR and AED. And we've set the criteria for each level, and that's been reviewed in consultation with schools to make sure that it's achievable as well. And for example, some of the criteria is that based on the number of students that they train in CPR, the number of years that they've been involved in Restart a Heart activity, whether they've got an AED and whether it's registered with us. And as part of it, to achieve the sort of upper level of the accreditation scheme, they also have to deliver a community-based project. So going out into the community and rolling out the training that we've provided for them. And just to close, I'd like to close with this concept. We all know very well about the chain of survival, and I'd like to introduce the concept of a golden link, and I think this is where children come in, that actually we can put in place a more valuable and precious link that we can develop these students that is more durable and longer lasting. And we need to capture the desire that's out there within schools to enrich and provide extracurricular activity as well. The demand is there. They just need somebody to help them meet it. And I think it's crucial that we reward schools and communities for their efforts by developing some kind of accreditation scheme to recognise the steps that they've taken. Thank you.
Thank you, Jason. Very, very nice presentation. Thank you, and welcome to the country that finally we have a law about school children training. So you think for a country, it's useful or not to fight for a law with a white paper that declare the rules of the game about school children training, and as you mentioned, maybe some rules that build the scheme of core curriculum for school training. It's very useful for you in UK because, for example, in Italy, we spent a lot of time in 2015. We had a law, but no implementation at the moment. So there is only some words on the stone, but nothing happened after that law. What is your dream for the future after you reach the goal of law in UK?
Well, it is law now. As of September last year, it is on the curriculum for first aid and CPR to be taught right through from primary school, in fact. So, I mean, it's something that has been worked towards for years, and ideally, aspirationally, I guess that every country would have this on the curriculum. And I think for me, it makes the delivery of what we want to deliver much easier because schools, as we've already talked about, teachers have a reluctance to actually teach this. And that's why for us, Restart a Heart has been so successful, because we offer as clinicians with a professional background to be able to go in and deliver this teaching. And that takes away the onus completely from the teachers. And much the same way, the ambassador program is providing a solution for schools about how they develop their own students, but it also achieves what we want to achieve in terms of teaching CPR in schools.
Okay, thank you, Jason. Tino, Pat, any other question from your side for all the guys here in virtual reality platform? Tino, you are on mute. Microphone, Tino. Tino, microphone.
Oh, yeah. There were several questions about difference in adult and pediatric CPR teaching. So for the panelists, do you see a difference in children and adult teaching? Maybe Jan, Gernot.
Well, we got experience just from our research, and we just find out that they can reach. We did the research on 1,000 pupils, and we found out that they reach 5 centimeters, 95% of the year of 12. And so we just put this point because it's just frustration for the pupils, for all their other pupils, if they can't reach the 5 centimeters. So we used mannequin by Practiman, that's a Spain product, and you can put such a click activator inside. And so it's quite good working. If you use adult equipment, they don't actually reach, and it's too expensive just to use it. So we use specially mannequins for school children. They are just smaller, just to take them home. That is a special features to take home. For us, it's important because for the multiplication of the showing and the performance of the CPR.
What we know from literature is it's not maybe the age, it's about, you need about 40 kilograms as body mass to be effective in chest compression. But if you don't have these 40 kilograms, you can learn a lot in doing these BLS courses. So for the smaller kids, if they learn how to make the alarm, how to bring the EMS in, how to even apply an AED, this all we can learn beforehand. And I think this is the most important stuff when we start earlier.
The problem is we just, what I didn't tell you is we just put from the 1,000 all over on the right, and we did a measurement on them all. And you went in the German school system is like 6, 7, 8 grade. So you can, when you do an application on this, you have to choose the grade. And so we said, okay, this is the 7th grade, and there are pupils because 12 till 14. And this, we said, this is the point just be used because when you train teachers, they have to know which grade they use. And this is the approach. If you don't select by kilograms, it's working, but the school system is not working like this. The school system is working on grade.
So this is local application of a general principle, but science teaches us that we can teach virtually from kindergarten on. And with this, I would also like to ask, because there were, for me, surprisingly comments on side effects of children teaching, even examples that kids played then after the teaching and doing chest compression on their own, on other children. Jan, you wanted to tell us something.
Yes, I think it's a very important point to discuss, because we always face these discussions when we approach the politics and the authorities. And I would strongly support what you said. It's so important that you start as early as possible in lifelong learning, because it's about rehearsal again and again, and you can reach children on the attitudes level very, very early. And if you reinforce every year, and they even see their progress when they're able to press harder and really to achieve the appropriate depth. And even we have some colleagues, female colleagues, who just have a weight of 45 kilos, and they have difficulties in compressing properly. So their task is to find someone who's able to compress better. And we can even, we could transfer that to the children if they're not big enough at that moment, that they look for someone, search for someone who's able to compress harder. And the other thing I would say, it's a bit different about side effects. We have a lot of side effects in adult training. For example, the side effect that the recovery position is taught in a very appropriate or very strong fashion, so that the recovery position is applied by a lot of adults when they face a cardiac arrest, and they don't compress, but they take the recovery position. And this is a side effect which is imposed, I think, by instructors who make it very complicated and who transfer something that you can make a lot of mistakes. While if you teach children and you have to stick to a simple message, you will never tell them that they can make a lot of mistakes, and they would never go be kind of distracted by actions which are not really efficient, as recovery position, as one example, and they are much more on track. So I think there's very, very important differences between adults and children, and we should use these differences to start as early as possible.
Mm-hmm. We have to look at the time because the time is running. Clint want to make a short comment, and then after Clint, Federico.
Just a short comment. Our teachers from primary school have told us that there's an age when little children are very memoristic. They remember a lot of things and they learn things by memory. And they've learned, a lot of them have learned the protocol so well that when they are 11, 12, the objective of the teacher is actually going to go to compressions, but they know they already actually have learned what they should do. And we have examples of 7, 8, 9-year-olds who have actually called the emergency services to whenever something has happened at home. And that's it. Thank you.
So before Federico summarizes what we learned, for me, the most important thing today was that we have to teach more often in short periods, also the children, and we have to listen to the children and the teachers. They tell us much more than we figure out. So these were impressive examples, all these developments when people really got back to the children and the teachers, and we have to make our programs for them. And with this, Federico, your summary, and after this, Patricia will announce the next webinar.
Thank you, Tino. As a summary, what we learned. So there are a huge amount of projects around Europe and UK that look into kids and training, and we are very proud of all these small projects that we this evening I think overall, a small comment from the previous question, ILCOR and the new BLS guideline suggests that we have no problem to give CPR to everybody, because it's very rare to somebody with CPR and AD. So if happened for adults, why we need to be, I can say, reluctant to apply to the children? So what we learned this evening, there are a lot of interest, because there are now over 4,000 attendees to this webinar on these topics. Maybe we need to organize a brainstorming after a day at Congress around this topic for the future. Maybe as a ERC, we need to bring new science on these school children training. There are a lot of science around. Maybe we need to push hard and fast the politician to increase the awareness on these topics. And Pat, the stage is yours. Thank you.
Thank you very much. So guys, just to bring this to an end, thank you very much for joining us. And for those of you who have an interest in the theory behind our education guidelines, then we'd welcome you to join our next webinar, which is on June the 17th. It's Educating Europe, the theories behind the reality. I'll be joined with my colleague, Andrew Lockie, Sabine Nebecker, and Tina will be there as well. Thank you very much for your participation, and we hope that you've really enjoyed the session. I think it's been fantastic. Thank you, everyone.
Thank you, Tino. Thank you, everybody.
Bye, all of you.
May the
Thanks
force
to
be
all
with
the
you.
speakers.
Thank you all.
Great job.